My name is John Draper. I am the Program Director for Research and Partnerships at the Stem Cell Network, and I'd like to welcome everyone back to Stem Cells from the Sofa, a virtual seminar series hosted by Stem Cell Network that is designed to reconnect researchers and bring expert content directly to your sofa. Today's talk will be presented by Dr. Jim Woodgett. However, before I introduce Jim, I'll quickly familiarize everybody with the Zoom platform. So, here we go. Here's the screen you're all viewing at the moment, and there's a number of options here. So the central part is where the content will be shown. Up at the top here, the view options, and then you have audio settings down in the bottom left and the Q&A button down here. So the view options allow you to zoom in or exit full screen if you wish to. The audio options, obviously you can change your audio settings, test your speaker, etc., and make sure that you can hear properly. Adjust the volume there as well. And then the Q&A session. Now this is the important part here, because obviously this is where you'll be able to interact with the presenter here. So you can submit a question to the presenter at any time during the webinar by clicking the Q&A button at the bottom of your screen. This will open up a pop-up box where you can type your question. You don't have to wait until the end of the talk to ask questions. You can use the Q&A window to ask a question at any point during the talk, and then Jim will be answering questions at the end of the talk. So, without further ado, now that you're all familiar with the platform, it's my great pleasure to introduce today's speaker to Stem Cells from the Sofa, Dr. Jim Woodgett. So this is Jim's bio that he provided me, so I'll read this to you verbatim. Jim is Director of Research at the Lunenfeld-Tanenbaum Research Institute, where he tries to steer a raucous group of ambitious, talented, and always optimistic researchers. Jim also runs a lab that focuses on how signal transduction regulates everything we do, think, and write, including this short bio. He obtained his PhD in 36 BP, which is, I believe, stands for before pandemic, and trained at the Salk Institute with Tony Hunter before starting a lab in London, UK. He moved to Canada and the Princess Margaret Hospital in 28 BP, and has been at the Lunenfeld Research Institute for the past 15 years. So that's Jim's bio, but Jim's also too modest to mention in his bio the numerous leadership roles that he has played in Canadian health research and the awards received, including membership of the Medical Advisory Board of the Gardner Institute Foundation, his election as a fellow of the Royal Society of Canada. As many of you will be aware, Jim is a prolific Twitter user and has used the platform to champion the causes of early career scientists and equity in science careers. On today's Stem Cells from the Sofa, Jim will be discussing the processes the Lunenfeld-Tanenbaum Research Institute is going through as preparations are made for easing the COVID lockdown, the conditions, and why the return to environment will not be the same as when we left it seemingly 10 years ago. Jim's talk is entitled, "My Dog Wants to Know When I Can Expect to Return to My Real Day Job in Research." So Jim, please take it away and let us know how your dog is doing.
Good afternoon. Okay, see, get this going. Share. And voila. Can you see that?
Yes, we can, Jim.
Great. All right. So actually, an alternative title for this might be Stem Cells Getting You Up Off the Sofa, because I'm sure after the past 8 weeks or so that you've been at home doing your duty, distancing and helping to flatten the curve, you're getting itchy itchy to get back to your research. And I know certainly that's what we find in Toronto. Even more keen than I is my dog. Actually, this is one of two dogs. It's on the right hand side. That's Penny, and she and her sister were getting a little bit hairy. This picture was taken before the hair was too long, so my wife and I spent Saturday actually grooming them for the first time. I will not share the pictures of them after grooming, although we did not too bad a job and did maintain their eyelashes. So the real question here is that how will society return to normality? And That's not going to happen for probably for at least a year. But there's as we can see, various societies around the world are beginning to relieve their restrictions and allow people to return to work. And I think research is a little different, as are many sectors, obviously very different. And a lot of us in research have been thinking about this for the past few weeks, and have come up with various plans. So I want to walk through what we're doing at the Lunenfeld, and hopefully you will see, you'll get some inkling and perhaps ideas about how to take some of the best practices that we've come up with and apply it to your own research environments and activities. So the Lunenfeld-Tanenbaum Research Institute is embedded at Sinai Health, which is two hospitals actually in Toronto. And so it's a little different from, for example, standalone research institutes or obviously universities and research labs in universities. But a lot of the principles are quite similar. So just to remind you, the reason we're thinking about this, at least in terms of returning to some level of normality, is because we have done a pretty good job of flattening that curve. The pink line here is the rest of North America, which, so there's the US there, and then that's us and Mexico, and we form, I think, about 2/3 of that little band. And you'll see actually the slide at the end. We're doing well, but we've got a long way to go. And it's all, but I think this slide from the Financial Times sort of brings it home. Even though we've turned the tide in terms of flattening and reducing the number of new cases, we're still living in an environment which is very much active in terms of community spread. And in Ontario, I think, if I remember yesterday, there were about 370 new cases, and it's very persistent, and this is not going to go away. So really the question is, how can you restore some level of activity without compromising the results and the efforts in reducing the rates of new incidents? So how do we control that? And I think everybody would ideally not want to have to worry about this until the community spread had gotten under much greater control, but clearly that's not going to be the case for quite some time. And for many, many reasons as well, there is a need to get back to work, not just because of the research, which is not happening, but also because of the economic impacts. And I'll touch upon that a little bit later. So, okay, we flattened the curve. When can I get back to the work I want to do? And perhaps some of you would never have thought you'd be yearning to get back to the biosafety cabinets and putting on latex gloves day in, day out. Of course, what happened in mid-March, there was a fairly precipitous shutdown of all the universities and research institutes over a period of about a week. And that was not so long ago. It may feel like a couple of years ago, but it was just after St. Patrick's Day. And I think that's when we knew we had to take it seriously. When the Irish had suspended St. Patrick's Day, that was the time to say, geez, oops, go away, can't take now. So, and of course we had little time to prepare, and I don't think many of us thought at the time that the shutdown would take 2 months or more. And so the labs were probably not shut down in the best way, and lots of experiments were halted, which in a way which was not, which was rather difficult to restore. So you'll have lost data, and you'll have lost experiments, and what have you. In between, of course, the intervening time's been really tricky. I think the people working at the bench have probably suffered a little bit more than the dry lab scientists who have been able to at least continue some level of their work on their computer work and biostatistics and what have you. And I'm sure you've all gotten your manuscripts up to date now. Those of you starting to plan your theses and what have you. I've done as much writing as you possibly can, and starting to run dry. So the problem really is that this is a real hiatus, and a hiatus that nobody had planned for. The fact that everybody is in the same hiatus, I think, is helpful in some respects, but because it's a shared experience. But careers have been put on hold, and in the meantime as well, research grants are being depleted as we've tried to maintain support, of course, for salaries and stipends and everything else. So the hospitals and the universities do, as I mentioned, have a somewhat different circumstances. Those of us working in the hospitals actually are classified as essential workers, and so we are able to work. We don't need to have the provincial okay to come back to work. However, all of the hospital research labs I'm aware of have, in essence, shut down, aside from COVID-19 specific research. The other aspect here is that, of course, to remember is that the hospitals are very much running 24/7, but they've also shut down in many respects in terms of, for example, the non-essential surgeries, the ambulatory care, and so the number of people actually working in the hospitals is also quite low, and that was to provide space for beds for the anticipated surge, which very fortunately didn't happen. So at Sinai Health, for example, we have an ICU which was expanded to 50 beds, and I think we have 14 of those are currently occupied. And that's the highest it's been for a little bit of time, mainly because of the long-term care disaster. In the meantime, of course, the things have happened, and we've seen CIHR and other agencies have actually launched some COVID-19 research efforts, which some of you, I no doubt, are participating in. And Stem Cell Network has also done this and was able to twist the government's arm and get some funding to support some COVID-19 research. And it's pretty amazing, actually, that the most recent CIHR COVID-19 competition is the second of two, which actually the deadline was yesterday, had 1,865 registrants, which is almost the same as a typical project grant competition. So it sounds to me like we've got a lot of people have actually been able to pivot some of their research to be applicable to COVID-19. Really, we've all become either armchair epidemiologists or virologists, much to the chagrin of the real ones. Anyway, and actually at the Lunenfeld, we have about 25% of our normal activities is continuing, but that's specifically focused on COVID-19 projects, both some basic science as well as some clinical research as well. So that's all good news because it's actually kept things running, and so in a restart situation, we're not starting from scratch, which I think is important, and this is true for a lot of the universities as well. So how can we restart research, and what's it going to look like? And this is a bit of a double question, because it's actually relatively easy to restart, but that's we've got to remember that's not entirely in our control. But I think it's also really important to note that the landscape has changed over the past 8 weeks, and we have to recognize and mitigate that. So the Toronto Academic Health Sciences Network, which is a network of, I think it's 8 or 9 hospitals with research institutes in Toronto, plus the University of Toronto, started thinking about this about 2 or 3 weeks ago, and we came up with 6 basic principles. The idea was that we would coordinate a restart, and to do it in a way which was relatively coordinated, and so that we could also learn from each other. And these are the 6 principles here. I won't go through them, but one by one. But there are some very important principles. The first is that we've got to adhere to institutional directives, and that's the case with any instance, because we don't control our destiny in that respect. The second, actually, I think is probably more important, which is safety first. That we really need to mitigate the risks associated with doing research and the environment we're working and doing research in, as well as the support staff. And I'll come back to that in a few minutes as well. One thing which tend to forget about. We do use a lot of personal protective equipment in our day-to-day lab work, gloves, surgical masks, that sort of thing. And the supply of those materials has completely changed in the past 2 or 3 months. It actually happened, it was starting to get scarce before the shutdown. And in a hospital or a university, we really can't interfere with the ongoing needs of the PPE for the frontline healthcare workers, and they get through a huge amount of PPE because, especially in the ICU and critical care units, and likewise in the long-term care facilities, there's now a lot more PPE being used there. So this is a limiting factor. I'll come back to the stage recovery. How do we get back to normality, or whatever normality means? We also need to consider equity. And this is in going into the recession, which we clearly are in. A lot of articles have noted that it's a she session more than anything, and that it's disproportionately impacting women who when people are working at home. The kids are at home because the schools are closed, and they often are the primary caregivers to children. And so a lot more of the burden goes there. And that's, I think, illustrated best by the quite stunning fact that the ratio of men versus women authorship on submission of manuscripts or preprints has been massively distorted towards men. And the various journal editors have also noted that. And then lastly, we need to have auditing processes to ensure that as we return to work, we're actually abiding by the guidelines. So we're in phase 0 right now at LTRI. It's a pretty easy phase, because basically it means what you're doing is preparing for people coming back. It's the launch pad. So we're ensuring that there's physical separation of space. We're using plexiglass, for example. We're converting our meeting rooms to lunchrooms, because one of our principles is that you can't have an in-person meeting of any more than 3 people. And we even discourage that using platforms like Zoom and Microsoft Teams and what have you. It's also a period where you need to build up some PPE, and the supply really isn't stable. So you can't take that for granted. We're also including in putting new signage and awareness around, and there's a little example here for welcome back to LTRI staff. Don't forget that you've got to wash your hands. That's probably the single most effective way to reduce your likelihood of transmission to yourself. Wearing masks when you can't physically distance. And the masking policies of different institutions are also, I know, going to be different mainly because driven by the availability of masks. We're also requiring each of our independent research labs to generate a plan. I can't turn to one of our investigators and know all the geography of their lab. We certainly don't know their domestic situations of the different members of their labs. And so we're asking each of them to pull together a plan and to submit it centrally to us, which we then will look at and approve. One thing we have given the go-ahead is to commence animal breeding. For our mouse facility, for example, we did ask our scientists to reduce the number of animals in their cage collection, and we know that that's going to take time for them to be restored. So they've actually been given the go-ahead now. So next, and I shouldn't reminder here, the trigger for going from phase 0 to phase 1, it comes from above. In our case, it's from the hospital. In the universities, it's probably from the presidents, and it may also be from the politicians, and we can't always rely on the politicians. Okay, phase 1 for us, we've got three phases. Don't worry, I'm not going to go through them. Phase 1 is 20 to 20% activity. And we can only do that if there's no community surge, that each lab, as I mentioned, has prepared a plan, that we've got protective equipment, and everybody is healthy, and the higher-ups are signed off. So the fundamental principle of this phase is to reduce the density of personnel and to tentatively explore safe practices, because we don't know, and identify problems and choke points and deal with the problems as they come along. So we've essentially all the labs are moving to shifts. So we're expanding our work times and asking people to avoid overlap. This also helps to avoid rush hour, for example, on public transit to reduce density. And as I mentioned before, you really need to take home situations into account. So some people would much prefer to work at weekends or to work in the evenings. And it really does mean it's a new way of working. There are lots of potential issues at this point where we need to evaluate, and that's, if there's carelessness or incompliance, if PPE has gone missing, and that's happened to us already. And also importantly, a lack of confidence in the mitigation processes that we're putting into place. And I'll come back to that in a second, because I think mental health and insecurity is a major issue. We expect this will be at least 2 to 3 weeks. It may go longer. But the idea here is that if before March 15th, whenever it was, we had 800 people here, 20% means that at any one time, we're not going to have more than 40 people on site. That doesn't mean only 40 people in a given day. Sorry, 160 people. That's 20%, not 40. That'd be 5%. So yeah, I can't do math. That doesn't mean only that those people can come in for a few hours a day. If you use shifts, then actually you can run through a significant number of people as long as they're coming in and they've got a plan. It's just at any given time, there can be no more than 20%. And that's because of social distancing primarily. Phases 2 and 3 actually are very simple. They just move to 40 and 60% density. And you might ask, why 60%? We don't envisage, at least in the foreseeable future, of having everybody on site at once again, until really after the vaccine and the pandemic is completely passed. And we really have no idea how long that's going to take. And we'll move to those phases as conditions allow. I think we'll learn that a lot can be done with phase 1, and we may actually never need to move to phase 3. We'll see. So what is post or co-COVID? I shouldn't say post, because we're going to be living with COVID-19 in the community, and the threat of it coming back for at least a year, if not two or more. So what it's going to look like, this is a pretty glum list of things, and again, I won't go through, but it's, this is, we're not in Kansas anymore. And I think especially for students, mentorship and training is going to be way more structured and less spontaneous. It's going to be very significant changes. Supplies are going to be more constrained, more expensive. Booking for access to core facilities or tissue culture hoods and what have you are going to be much more difficult because you can't have people sitting next to each other. So this has to be spacing. And so again, this is all about the principle of reducing density. You're going to smell of Virox and Purell because you're going to be washing your hands as often as you possibly can. We're going to be disseminating information in different ways, preprints, for example, and we're going to be doing a lot less travel. So you'll see more of your supervisor, which is good or bad, I don't know, but mainly on the screen. And they'll be accidentally muting themselves all the time. But there again, there's not going to be so many commercial reps bugging you, although at the same time, they won't be bringing Tim Hortons Timbits. And I think this is just my thoughts here. I think health research in Canada is going to be shrinking by 20 to 25%, in particular because the health charities are having a very, very tough time. Their income, their donations have gone down by 40 or 50%, and they're going to have to cancel future competitions and probably reduce the amount of funding of grants they've already funded. So hopefully that's going to be a temporary measure, but I think we can expect that. And I think it's also, and I've got no clue here what's going to happen, the universities are going to undergo very significant and unpredictable change. They're going to lose or have a big reduction in their international tuition, but I think people are going to be looking at universities in a very different way, given that everything's going online, at least for the next semester in the fall. It'll be interesting. So just coming to the end, a reminder that we're nowhere near exiting this pandemic. Again, this is from the Financial Times. We've pretty much flattened off in Canada. There's some parts of the country are doing much better than others. Ontario and Quebec are really not doing terribly well. And it can flare up again, as we've seen in parts of Europe and also parts of Asia. So, if there is another flare-up, another spike in cases, we're going to be back to where we were in mid-March, and there could well be much more restrictions put into place. I think a question there is how much society will tolerate that. Many of us are very fortunate in that we've had a steady income, but people have been put out of work, as you know, and being supported through government support mechanisms. But that's still not. It's a very, very tenuous and difficult situation, and some of those support mechanisms are only going to last until June to July. I think what we can expect is a surge in testing in Canada, both at the PCR level and also blood tests, in terms of trying to monitor for outbreaks. And the reason I put that in is because I think there are some research opportunities here. If you're a good researcher, you never look a challenge in the face without asking questions. And I think a major understandable concern of the public is in them coming back to work is am I safe? And that we have to be thinking about that for our researchers and our employees as well. So one of the ways, I don't know how to answer that question, to be honest. And I think there is a significant number of people, our colleagues, maybe some of you, who are very, very concerned about this. And we have to understand that, the reasons why. So at LTRI, we're actually planning a research study looking at saliva PCR-based assays and a fingerprint serology test serially over a year. And it's going to be voluntary, obviously, and aimed at volunteer subjects who are asymptomatic. Nobody who's symptomatic is allowed into the hospital, and you need to get tested anyway. So we want to learn about things. We want to give feedback to people, so to give them confidence that if there is an outbreak, we'll be on top of it very quickly. I think the issue of asymptomatic spread is one which we're going to have to deal with. And I just stole a little bit of data from Anne-Claude Gingras, who's leading our effort here on serology testing, because serology really is just surveillance. But she and colleagues at U of T, Tanya Watts and others, have been working on displacement assays to actually test to see not only if you've got antibodies, but are they neutralizing. And I think that's going to be very interesting, and it's going to give us more information as we go forward. Of course, with immunity, we don't even know how long immunity is going to last, and that's what we're going to be looking for. I should also mention here that we're fortunate at Sinai because we have an assessment center on site. And so anybody who turns out to be PCR positive, we refer to our OC Health and Safety group and get tested by the hospital clinical group. Larry Ng, who's our manager of our IT, put together this daily tracking web app that we use, which we found very, very useful in monitoring compliance. And the reason for this was actually, and I know you can't say it's too small, but you just log in every day when you're on site, and you tick off which places in the hospital or in the research institute you've been. And that allows us then, if there is an outbreak, to do contact tracing. It's going to help for that. And we limit the data to HR, other than collated data, which we track in terms of the number of people working on site. So those are the sorts of things I think we can put in place, and it's important to collect data, and also to provide evidence back to your faculty or to your hospital that actually you're being very useful. Oops. And the last thing, I'll just finish with Savraj Grul. He's a professor at University of Calgary, has actually collated a number of publicly available return to lab guides, and it's a Google Doc. Unfortunately, it's got that horrible URL there. But if anybody wants that, I can email it to them. And actually, if you just go to look up Savage on Twitter, you can find it, the link there as well. And I think there's about 7 or 8 different guides there to return to work. So gone on a little bit long. I'll stop there and be happy to answer any questions.
Thank you, Jim. Thank you very much. That was great. So there's questions coming in, and please do take your time to type the questions into the Q&A box just on the bottom of your screen there that you can pull up with the Q&A button. So starting with a question from Sama. Given there is already COVID research happening in the Institute, you mentioned approximately 25% capacity. Does the phase 1 20% capacity mean that you're actually restarting very few labs in phase 1? I think it means.
Yeah, that's a good question. Actually, there's only 3 or 4 labs out of something like 40 different labs. So it's very uneven. And that 20 to 25% of people means is actually includes a lot of the support staff who've had to come in, for example, for HR work or for maintenance. And so the actual number of people working in the labs is way below that. And what we've said to our labs, once they give us a plan, they have to give us their own personal lab plans to identify how they're going to comply with 20%. It means 20% of their people for everybody in their groups, and so that's the administrative assistants, everybody. So we think actually if we added it up, the number of people in phase 1 per day, it's going to be more than 20%. It's probably going to be more likely, more like 40%. Having said that, we're also encouraging people who can stay at home to stay at home. If you're doing dry lab work and you can do computational work at home, then just stay at home because your risk is reduced. There's small risk that there is, and it just helps us in terms of density. So the primary purpose here is to reduce density. And there are lots of, I get all these questions all the time from our investigators. If I've got somebody working in the mouse facility, does that count as my 20%? And it's what we're saying to them is really you should be running, being very careful of who you've got on board, that they're making sure that they're keeping at least six feet or so away from each other and are not congregating. And the 20% is really the idea that we should be at a much, much lower density than normal. So, it's not going to be, we're not going to police this. We're not going to have the Gestapo walking around, but we are going to keep a measure and look out. We're actually trying to get people to say, it's for everybody's best interest. If you notice somebody who isn't complying very well, it's to point out to them because they're putting themselves at risk as well. So hopefully this will be a joint responsibility, and I think that's the best way to achieve the most practical compliance.
Okay, thank you. So the next question is from Sharon Cole. Has the Lunenfeld considered testing everyone as they come into the building?
So no, we do have a screening because we're a hospital. We do have door screening, but the door screening is pretty. You just show your ID badge, you put on some hand sanitizer, and read a statement, basically a little poster which says, "Are you symptom free?" And does nobody at your home have any symptoms? That's the only screening we do. It's actually quite expensive to do screening. If you're going to do PCR screening, you only get the result the next day. So at best, there are some point of care devices which are coming onto the market, but each of those costs, probably each test is $10 to $20, and we just couldn't afford to do that. And so even there, it takes half an hour, right? So you can't actually do testing as you're coming in, but certainly we are screening people for them to be self-declaring. And I know that hospital sick children actually on their ID badges, every so often they have a sort of compliance sticker which changes color, COVID-19, and they only get a sticker if they have agreed that in fact they are symptom-free and they are aware of all of the the conditions for entry. So different institutions are doing it in different ways. It's going to be more difficult, I think, in university campuses where there are multiple buildings. How do you control access there? But again, there are going to be different solutions. But I think the solutions will be very dependent upon the physical circumstances.
So I just as a follow-up, Sharon has put that she's referring to temperature screening like they do in Taiwan and South Korea. Is that of utility?
I mean, we're scientists. This is bullshit. Measuring temperature has been shown not to actually be useful because if you have a fever, you know you have a fever. I shouldn't say it's complete garbage, but it really, I think, is a false sense of security. So yes, you can do that. It isn't going to capture asymptomatic people who are I think, the most at risk. And I think we do have, I hope, we've learned over the past few months that if you've got any symptoms, you do not come to work. And the problem is that you are asymptomatic and probably PCR negative for the first 2 or 3 days after infection. And your rate of ability to infect others is reduced until you become symptomatic, but it's still real. And that's probably what's causing a lot of the leakage that we're seeing in the shutdown. That's why we're still getting community spread, unfortunately. That and kids.
Okay, so there's a question from Judy Isles, which is, what will society intolerance look like?
Yeah, I think we're starting to see that, as Doug Ford called them yahoos, demonstrating outside of Queen's Park, and we've seen it in BC where they've, covidiots or whatever, blocking ambulance bays. I think we have to recognize that for some people, there's no sympathy for them, but for a lot of people, they're in a very, very difficult economic situation, and it's incredibly frustrating for them. And they don't know, they can't travel, they don't know what to do. So I think the frustration is going to increase, and the ability to ask people to sacrifice their personal freedoms and stay at home is going to be strained. So I don't think we've got much choice about this. We're a free society. We're not like as happened in Wuhan or in China, where their lockdown was police enforced and army enforced, and it was very, very effective. Mm-hmm. But Canada isn't like that, and so I don't really see that we are physically going to be able to have this level of lockdown that we've had over the past 8 weeks, and even that level of lockdown hasn't been sufficient compared with what we've seen in places like Singapore, where they've been much more effective. So we've also been fortunate not to have the same level of community exposure, but at the same time, we've seen that 80% of the deaths have been in long-term care facilities, and that's a pretty lousy outcome for all the efforts we've made.
Okay, so a question here. Thoughts about which sector of our staff comes back first? Students in the second phase, question mark?
No, we're not discriminating between the students and postdocs and staff, technicians, what have you. We're leaving that again to the investigators. And the rationale for that again is that we don't know quite the type of work that they're doing. And as I mentioned, I didn't point it out, I didn't read out that little bit. I think that the nature of research is going to change. It's going to become, unfortunately, less directly collaborative. That doesn't mean we're not going to collaborate, but it's going to be more difficult to work as teams, physically as teams. The other element, I should say, there is a difference. Because the hospital has a lot of activity going on, our microbiology lab, for example, is doing a lot of PCR tests. They're doing over 3,500, 4,000 a day, and we're expanding that. So we've actually been helping them, and they've asked us to reassign some of the technicians in the institute, and that's gone very well, and it's given those technicians other things to do, and it's also helped to relieve some of the pressure on the grants. we don't allow the students to do that. And that's because the students aren't covered at the University of Toronto for the insurance for working, doing work which is not directly related to their degrees. But in coming back to work, returning to work and carrying on your studies, the students will be just treated in exactly the same way as the postdocs and the research associates.
So connected to that, as a PI, do I include myself in the 20% to supervise, or is it better if the PI stays home?
I don't know. Depends on how much you value yourself as a PI. I mean, there's a lot of stuff that PIs do, as everybody knows, which they do in their office, which is actually means you can self-isolate very, very well. But I think the PIs have to demonstrate, I work from home when I can work from home, and I come into work. I'm in work now for a couple of reasons. But I think we have to try to reduce presence as much as possible. And I really do think we've become reasonably good at Zoom and Microsoft Teams and what have you, such that we can really interact and teach and have lab meetings in a fairly effective way. I really don't think there's much need for direct face-to-face contact, and so I would leave it to the PI's discretion. But I would say that you shouldn't be. If you want to set an example, set the example of working from home, because that's. I do worry that people will feel, with the return to work, that they feel obligated. Students and postdocs in particular, you work really, really hard anyway, and I worry that they'll feel obligated to do that. And so I think it's very much incumbent on the PIs to ensure that their students and postdocs feel comfortable and do not feel under any pressure.
So if a positive case is identified among research staff, do you anticipate the Institute will retreat back to phase 0?
That's a good question, and it's conditional on the type of incident. We, touch wood, have not had any incidents over the past 8 weeks. That's not the case in all of the hospitals in Toronto, at least. So that's one of the reasons we're doing the check-in every day, asking people to. So the check-in has 2 bits of information. One is when are you actually on site, and then where have you been? And it's just a checkbox to the various floors in the research institute. And so we're hoping with that to be able to identify and tell people who potentially have come into contact with that person. Again, that's why physical distancing is really, really important. If somebody is contagious and develops symptoms afterwards, but they've maintained physical distancing, the likelihood of transmission is much, much lower. And in the hospital where this has occurred, we've had a couple of people, for example, in the hospital HR in the past couple of weeks, they were able to isolate those people. They gave a letter to the other people. They were monitored, and some of them were tested, not all of them. So it really depends. If there's a case of clear nosocomial transmission, i.e., somebody coming to work and actually getting the virus while they're at work from a coworker, that's a different case, and that may require us either to go back to phase 0 or to close down a portion of the institute. And that's what you really do want to avoid. And it may happen, but let's hope not.
There's a couple of questions that focus on whether implementing some kind of shift process for allowing lab members to access facilities will be offered as well.
Yeah, most of the plans, we didn't stipulate what people should do. We recommended that they should look at shifts, and that's what most of the plans that we've received to date have done. And they're pretty kind of draconian. That's what I mean by it's a very different circumstance. Some people are going to be starting work at 6 o'clock in the morning, working till, say, 2 o'clock. Others are going to be working from 2 o'clock to 8, 9, 10 at night. Some are going to be working just at the weekend. So it really depends. And I think what's happened here, and this is, I think, a really key thing I want to emphasize. Every group has a very different way of working, and they know themselves, right, what that is. So if you discuss it with your group, there are some people who would much prefer to work early or late or whatever, and it's just easier for them, for their circumstance. And so a lot of the drive towards these different shift times, and quite unusual shift times, has come from the students and the postdocs and the staff themselves. There is a little bit of a concern here, though. We're not encouraging people to be doing overnight work, even though actually our microbiology lab, for example, the clinical microbiology lab does work 24/7. We're not encouraging that because we do worry about safety and working just as normal as you would, but also some of the facilities. We can't have our cores open through the night, for example, like fax core or imaging and that sort of thing. So you have to be, there's going to be some limits. And even our mouse facility, although it used to allow people to work pretty much 24/7, they're also restricting ours at the moment to some degree, and they may loosen that up over time. But again, it's going to be very, very dependent on each institutional circumstance. So that's why it's really important, I think, for every institution to have to come up with their own plans and make it very transparent and interactive, and talk to people as to what they feel are the best solutions.
Okay, so can you manage a few more questions?
Sure.
Okay. Can you elaborate on the individual plans and what each research institute is looking for?
Well, I didn't go through all of the other institutions' plans. I do know about some of the ones in Toronto. Some actually have, we have 3 phases. I think that's sort of a detail. Some have got 2 phases. It doesn't really matter. The principle here is, how do you reduce the number of people in a given area at any given time? There are some differences in terms of masking policy. As I say, I think that's going to be somewhat contentious. For example, the infection control people in the hospitals can't agree on this in different hospitals. And in part it's because, so in research right now at the Lunenfeld, the policy is that we don't give masks to people who are working unless they are working in patient accessible areas. And that's because the hospital doesn't want us using PPE and potentially diverting from their stream. So other institutions, I'm sure, will be able to manage to get some PPE, and masking will make sense. But other infection control people say, if you are safely distancing, you do not need a mask. And when we saw this sort of level of contention coming from the public health officer of Canada, Theresa Tam, and she was sort of criticized for it in changing policy with masking. But I think, I think there is, the idea is you need to wear a mask if you can't physically distance. The protection afforded by certainly a cloth mask or anything other than an N95 mask is you're protecting other people. You're not protecting yourself. Now, of course, if everybody's wearing a mask, then everybody gets protected. So that's the principle of an all mask policy. But it really is is pretty much as effective if you just maintain distance. That means you should make masks and face shields available to people if they are, for example, going to be in a situation where they can't physically distance by 6 feet. And in some laboratories, it's just impossible to do that. And it's also, just walking down the corridor, you see somebody coming towards you, you duck into a doorway and you wait for them to go by. Elevators, we have little cross marks on our elevators. 6 people, it just means you have to wait for the elevator for longer It means you don't go down to the food court. Maybe you plan your day, and it's quite possible. It's a different way of thinking, but I think it's something which we can adapt to pretty well.
Okay. Someone's written, what do you think of the 10-4 rule, work 4 days, off 10 regime, recently put forward in the New York Times, if you've heard of that?
Yeah. I mean, it's interesting. I mean, that's sort of, I think is, in a way, it's a surrender, because we are surrendering to the virus. The virus is not going away. The idea there is that if you pick up the virus, you're going to be asymptomatic for several days, and you're also not going to be infectious for the first few days. That's the day 4 thing. And then you take 10 days off. So if you do develop the symptoms where you are most infectious, you're away from everybody else. I don't know. It's an idea. It probably makes much more sense in certain sectors than others. It doesn't. I think it's going to be very difficult for research because you've got experiments where you're having to if you had to stay away for 10 days, just having those little blips and bursts of activity, it would be very, very difficult. So I don't think it's going to work for us. But I think this is a good example of the types of thinking now as to how do we live with this virus, which is obviously what we're going to have to do for the next few years.
Okay, how about this one? How will you manage local collaborations, i.e. personnel from outside the Lunenfeld coming over to work on site or vice versa?
Yeah, it's again, that's dependent upon institutional policies. It's difficult. I think, especially if you're on a university campus and you need to move between different buildings, I would hope the universities would allow policies to do that, but obviously it doesn't allow so much isolation. The hospitals in Toronto, at least, we have several downtown, so there's lots of interaction between them. And in fact, we share a mouse facility with sick kids. And our policy is that you don't visit another hospital if you've worked in another hospital. And that's a policy of the healthcare workers as well. It just makes life more difficult. We have allowed people to come in on a prearranged. We give them a note. They have to show the note to the door screeners, and they can come in if they need to do particular experiments. But it's very cumbersome, and I do think we're going to find a lot of these points of inertia, and you just got to have patience to get around them. It's going to be very difficult for some types of research, and but I'm confident we'll find workarounds, and we'll adapt. And it may mean that if you have to work on two sites, you would work at one site 1 week and another site the other week, and find ways around it in that way. But I mean, another issue. I don't think I'm going to miss it, but we used to, in science and research, we used to travel a heck of a lot, and there aren't going to be conferences. There are not going to be those sorts of meetings. We're not going to have grant panels, face-to-face grant panels. So it's just a new level of reality, and we'll adapt to it.
Okay, I'm just going to probably end there. We've been talking for quite some time now, so I'm going to share my screen here, and thank you very much, Jim, for taking the time to answer people's questions, provide all of these really important insights at this current time. I'm sure people are thankful for that. And I will just move forward one slide here. And so I'm going to tell you a little bit about the next Stem Cells from the Sofa event, which will be held at 1 p.m. On the 3rd of June. This is 3 weeks from now, so we're taking a short break. It will feature Dr. Veronique Moulin, professor at University Laval, director of the Regenerative Medicine Division of the Research Center at CHU de Quebec. Veronique is leading a stem cell network-funded clinical trial to evaluate the efficacy of skin substitutes reconstructed using tissue engineering mods. During the last few months, Dr. Moulin's team have continued to produce skin substitutes using despite the pandemic, but following public health rules. Here, Dr. Milan will present the latest results obtained since the trial started in her talk entitled Treating Burn Patients Despite COVID Pandemic and Social Distancing. You can register for her talk by scanning the QR code here or visiting the link here. Updates on SEN events, news, and stem cells from the SOFA talks are regularly provided on our Twitter feed, so subscribe at the Stem Cell Network. And please complete the poll that you will see popping up as you leave this. We would love your feedback. Okay, thank you very much, Jim.
Welcome.
Bye.